Welcome to Family Planning and ALS. I'm Nicole Sammartino, Community Education Manager for the Les Turner ALS Foundation. I want you to know that you're muted and not on camera, so please relax and enjoy the presentation, which will last for about an hour. You will notice a chat box to the right of your screen to enter your questions, and we'll have a Q&A discussion after the presentation. Lastly, this program is being recorded and will be available to view on our website in the next week or so. So let's get started. I want to thank you again for joining us with Lisa Kinsley today. We know that the decision to have genetic testing for a familial ALS gene is important and may have many implications for those interested in starting a family. This talk will review family planning options available to individuals to reduce the risk of passing on a genetic disorder. We'll review what is involved in each option, as well as some of the biological, ethical, and financial considerations that play a role in this most important decision. Before I formally introduce you to Lisa, I would like to tell you a little bit about the foundation. I'd like to thank our industry partners for making the learning series possible, and Gilbert and Jacqueline Fern Foundation. We are leaders in comprehensive, personalized ALS care and research. We realize that people living with ALS may feel overwhelmed and unsure of what questions to do and what questions to ask. The Les Turner ALS Foundation exists to care for those affected by the disease, guide them to answers, support them and their loved ones, and provide hope through scientific research. Our support services team is comprised of knowledgeable and compassionate nurses and social workers with many years of experience guiding people and their families affected by ALS. We offer a variety of services, including but not limited to what you see on the slide here, including care visits by ALS support services coordinators, support group meetings, as well as in-service education for community care. At the Lois Insolia ALS Clinic at the Les Turner ALS Center, we offer access to enrollment in clinical trials and dedicated clinical trial coordinators. We are Chicagoland's first and largest multidisciplinary ALS clinic with the highest number of neurologists and dedicated pulmonologists. And we offer multidisciplinary care that brings together an experienced team of neuromuscular specialists in one clinic to provide comprehensive support for you and your family. So it's my pleasure to formally introduce Lisa Kinsley. Lisa's well known to many of our Les Turner ALS families through her work at our Lois Insolia ALS Clinic at Northwestern Medicine. Lisa graduated with a biology degree from Valparaiso University and then earned a master's degree from Northwestern University's Genetic Counseling Graduate Program in 2009. And then she received her board certification in 2010. Currently, she is the Genetic Counselor Resource Coordinator for Northwestern Medicine's Neurology Department, as well as an Assistant Professor of Neurology at Northwestern's Feinberg School of Medicine. She provides genetic counseling for patients with a variety of neurogenetic indications in the MDA, ALS, epilepsy, cognitive neurology, and movement disorders clinics. She also sees patients for a variety of genetic indications in Northwestern's Neurogenetic Counseling Clinic. So it's my pleasure to introduce you to Lisa.
All right, thank you so much. Can you guys see? I think I was flicking around there, but do you see my main slideshow? Am I good to go?
Looks good.
Okay. All right, so again, thank you, and thank you for inviting me to talk today. This is definitely something that I talk to most of my patients about, so I'm more than happy to kind of get the word out and have the chance to talk to a bigger group of people and give people a chance to learn about these things and ask questions if they have them. So feel free to throw your questions in the chat as you come up with them. So again, thanks to Les Turner for presenting all of these talks. I think it's really great. They're putting these educational series out there. I am a member of the Lois Insolia ALS Clinic, so this is kind of the schematic here. I'm involved in a few of these boxes. But basically the talk that I'm going to give today is really more focused on genetic testing and what are the things that we can do with those results. So genetic testing is a very important decision. It's a hard decision to make a lot of times. And part of that is due to the implications that could have. But one of the reasons that I talk to a lot of people is that they're interested in using those results for different kinds of life planning. And one of those things is family planning. So this talk will talk about what those options are if we know that there's a genetic variant, and then some of the things to think about that might not be kind of the top of your mind when you start processing these options. So in case you weren't able to make the first talk, I'm going to give a brief overview of who I am and what I do. Because I still get this question when I tell people what I do for a living. So I'm spreading the word about genetic counseling. So who are genetic counselors? So I am a health professional. I have a graduate degree in genetic counseling, and I have experience both in medical genetics and psychosocial counseling. A lot of us work as members of healthcare teams. We provide information and support to families who have any number of genetic disorders and their family members who might be at risk for those conditions. I'm also a resource for healthcare professionals and the general public. I give a lot of talks like this to kind of educate people about, what goes on in sessions and general questions about some of the conditions that I see patients for. And a lot of genetic counselors, myself included, also engage in research activities related to medical genetics, genetic counseling, gene identification, lots of stuff going on in research and genetics these days. And genetic counselors are definitely involved in those types of things. So the process of genetic counseling is basically helping people understand and adapt to the different ways that a genetic diagnosis or a genetic contribution to their symptoms can affect them. So this could be medical management, if there's medication changes, different things that we'd recommend other specialists to see, psychological effects of, hearing that someone has a positive or a negative result, how they see themselves fitting into society, family, different things that can come up as a result of going through genetic testing or having a genetic diagnosis. And as a part of that, there's kind of three things that we work with to do those things. So there's a lot of interpretation of family and personal medical histories to get that assessment of what are the chances of something will recur or occur in the first place. Providing a lot of education about inheritance, genetic testing, medical management options, if there's any prevention options, resources that are available for patients, and research opportunities. And then counseling to promote informed choices. Not everyone has to do everything that's out there, so helping people come to the right decision for them is important. And then adapting to that risk or that condition or whatever we're looking at for that person or that family. So as my role in the multidisciplinary clinic, I am primarily involved in testing, but as a part of that, we talk about a lot of different things. So, I'm taking family histories, assessing those for patients and practitioners, putting in those orders for genetic testing, interpreting the results. Sometimes the results aren't necessarily straightforward. So interpreting those for everyone involved, counseling patients, family members for the implications of those, and then if there's pre-symptomatic testing, other follow-up visits, those are all part of the kinds of visits that I see patients for. So last time we talked a lot about ALS genetics. So we talked about, the different genes that are involved, DNA, chromosomes, negative, positive genetic results. And we're not going to go into as much detail. I think that presentation is saved, but just to give a little context for what we're going to be talking about today, I'm going to talk about the breakdown of sporadic ALS versus familial ALS. So most people who have an ALS diagnosis have a form that is considered sporadic ALS. So, excuse me, this would be about 90% of people with ALS. And this basically means that no one else in the family has an ALS diagnosis or a related diagnosis. Sometimes we ask about other things like dementia and Parkinsonism, other neurological conditions that we're learning may be kind of related, but basically no one else with anything that we can point to as related. Genetic testing is possible, and we do frequently order it for people who have suspected sporadic ALS. It's usually negative, but about 11% of the time we do find a genetic cause for those people. Sometimes that's because we have, information about family history that's not accurate, or people were adopted, or people passed away earlier than they would have developed symptoms. So there's lots of reasons that can be masked, and one of the reasons that it's really helpful to get a family history if possible to help us interpret a genetic result like we could get. So the reason that genetic testing is usually negative at this point is because sporadic ALS is likely to be multifactorial inheritance. So kind of like diabetes or heart disease, it's a combination of genetics and environmental risk factors that together make someone at risk for symptoms. So I used this analogy last time that your risk for developing ALS, for example, is like a jar, and there's different marbles that represent risk factors. And if the jar gets full, that kind of tips someone over the threshold to develop symptoms. But depending on how many genetic factors a person has, environmental factors, other things that we don't fully understand yet, people may never, fill their risk jar, so they don't go on to develop symptoms. The tricky part is we don't know what those genetic factors are. So it's not something that is testable on this side of things. We can't test for those blue marbles and tell people how many blue marbles of genetic factors they have. That might change in the future, but for right now, that's not something that we can really quantify with any testing that's available. On the other side of things is familial ALS. So this would be about 10% of people who have an ALS diagnosis. They'll have at least one other family member with ALS or related diagnosis that I mentioned earlier. Genetic testing is possible, and this is another group of people that we frequently order genetic testing for. For these folks, we're able to find a genetic cause about 60% of the time, which means basically that we know a lot of genes. We know some of the more common genes that can cause this, but there are still more out there that aren't identified yet, so we can't test for them. So we don't know what all of our genes do. We can test the ones that we know about that have been linked to a particular condition, but we can't test things that we don't know about. So that's the limitation, and research is working to identify more of those genes, so more comprehensive testing is available. Most of the genes that we talk about when we talk about ALS would be autosomal dominant. So that translates to about a 50% risk for offspring of an affected individual to also be at risk for developing symptoms. So this is kind of that breakdown. The flip side of the chart, so 10% of people have that familial form, and we are able to see the breakdown of the different genes that we can find for those people. So for testing, the moral of the testing story is that we do need a positive test result in order to offer family planning options for people. So sometimes testing can come back inconclusive, and we really can't use that for family planning because we need to have a definitive, yes, this is the cause for this individual or this family, and use that information to make decisions. Inconclusive test results are not an option for these types of things. And like we discussed, not everyone with ALS will have a findable genetic variant. So definitely recommend genetic counseling to talk to, patients and families to discuss these things, go over testing results, make sure that the most comprehensive testing was ordered, and then we checked everything that we could check, getting people involved in research to be on the lookout for those newer genes. And if applicable, talking about family planning options that we could look into. So what are the family planning options that we have when we're talking about reproduction for people who are in this situation? They want to start a family, but they're worried about the risk of passing on this genetic cause for ALS. So first of all, none of these reproductive options are necessary. Family planning is not mandatory. It is totally fine to discuss these options, learn more about them, and then choose none of them. I know we have, I talk to people who definitely choose that option, and, just kind of looking at why they choose that option. A lot of people cite the fact that no one knows what the future will hold. I think that's very true. We don't know what medicine will look like 5, 10, 30 years from now. Other people cite their faith. They want to have children, and whatever happens will happen, and that's the outlook they have on it, and they'll deal with things as they come. Other people cite, research. There's a lot of promising research with that will hopefully result in methods to treat symptoms or prevent symptoms. So that is definitely something to look forward to. And really any other reason, if people aren't comfortable with any of these options, if there isn't one that's a great fit, this isn't something that you have to do. Just throwing the options out there to let you know, because there really isn't, you know, one size fits all option for everyone. There's a lot of different things that factor into making this decision. So when we do talk about kind of interventional things that we would have as an option, one of the ones that we talk about is adoption. So I've kind of put this in the context of a pedigree. So this is what a pedigree or a family history looks like when we take it in clinic. Maybe a little bit neater because it's on the computer, but basically squares are males, circles are females. If someone is colored in, that means that they have whatever condition or symptom we're tracking through the family. If someone has a line through them, that means that they have passed away. And it's a little bit more simplified. Usually I'd have writing underneath giving me more details about people, ages, things like that. But in general, what I see when I'm looking at this is I see a family where this individual at the top here, the blue square there, that's a male who had ALS and has passed away. And he and his partner had 4 children, 2 boys, 2 girls, and one of those boys has ALS or tested positive. And then my focus is over here on this this female, the circle over here on the right, who has the arrow pointed at her. The arrow indicates that she's the proband, or the person coming in to talk to me. And let's say that we know that she has tested positive for the family's ALS gene. She wanted to start a family, but she was worried about that risk to pass on, so she chose adoption. So she has adopted a little boy, a little girl, and obviously this has eliminated or greatly reduced the risk of her passing on that genetic disorder. So obviously there's all different kinds of genetic things out there, so we can never say that people will never get anything, but we know that she's not passing on that ALS gene that she was concerned about. So obviously that would be a pro. Some of the cons that we talk about and think about with adoption would be that it can be an expensive and lengthy process to go through. There may be support from family members or, you know, different organizations, but in general, it's a tough process to go through. Some people feel that having a biological child is important to them, and this would be, in most cases, a non-biological child if that's of importance. And as I alluded to before, we may not, and in many cases we can't know, you know, all of someone's genetic background. I've had a few requests lately for people wanting like full genetic screens, just to let them know of any risk, and that is not something that exists yet. So we don't have a way to, you know, fully get a picture of someone's genetics. We kind of use the tools that we have to learn what we can. But this would be, you know, a way to at least account for one of those genes that we know is in the family. And this is an option that's really not necessary to have a positive test. So if we had tested, you know, the affected family members and everything came back negative, what we would be able to tell this woman is we'd say, you know what, we can't test you to know if you are at risk. What we can say is that you are at up to a 50% risk. So this is an option that, you know, we don't know her status, but if she wants to ensure that she doesn't pass that on if she does have it, adoption is and available as an option, even if we don't have a findable genetic cause for an individual or a family. Another option that I talk about is donor gamete, so donor egg or donor sperm. So we're at the same pedigree, and let's say that this individual, this female with the arrow pointed at her, she tested positive. She did not want to pass on that affected gene, so they chose to have a donor egg. So we have this other individual, the circle with the D in that just indicates in pedigree language that it's a donor egg that was used to conceive this male down there. And then on the other side, it's just how we indicated donor sperm. So these are individuals who have chosen to get donor gametes to conceive pregnancies and to start their families. And this would be another one where we don't necessarily have to have a positive genetic test. People can choose to use these donor eggs or sperm, whether or not they are gene positive or if we have that gene. So that is another option for that scenario. This is a thing or a process that might involve several different steps. So depending on the center that you use and then the specifics of each individual's case, we might be looking at in vitro fertilization or IVF, so combining the egg and sperm outside the body and then transferring those for implantation and pregnancy. Might be looking at artificial insemination, finding an egg donor, a surrogate. There's lots of different complexities and different options that people can look into and choose depending on the different other needs that they might have for achieving the pregnancy. So there's a lot of different costs that go into all of these and the different levels. And each of, basically overall the donor gamete option has, like the other ones, has pros and cons. So some pros, there's definitely that decreased risk of familial ALS. For the kind of biological side, it would be partly related to the parents if that's important to a couple. On the con side would be, the cost for these procedures, depending on what people are interested in going through and need for their process. That can add up, may or may not be covered by insurance, depending on the policy and what little caveats are present there. And as far as the donor's family history, I know a lot of facilities that do, donor eggs, donor sperm, they do some limited carrier testing, just to kind of minimize the chances of a recessive condition popping up. They may also review family history to see if there's anything, anything that would raise any red flags for, other things that could be inherited. So that's something to consider, but again, we can't screen for everything. And like I said, this is another one where we don't have to have a positive test for this to be an option for a family or for a patient. So this is another option. So this would be the option of prenatal testing. So for this pedigree, we have our proband over here on the right, who we know has tested positive, and she has this diamond with a P in it connected to her. So that indicates that she is currently pregnant. The P stands for pregnant. And the diamond means that we don't know if that individual is a circle or a square yet, basically. So she hasn't found out, the gender of the pregnancy. So if a person chooses prenatal testing, this would be basically getting pregnant naturally and then testing that pregnancy to determine whether or not the affected copy of the gene was passed on. So this is an option that we do actually need to have a positive genetic result. We need to know what we're testing that pregnancy for, so we know what what to look for to get that definite yes or no. And that's important because when we talk about prenatal testing as a part of a genetic diagnosis, that usually would come along with a decision to continue or not continue that pregnancy. So we do need to have that positive result to be sure that we're giving people accurate information to make that decision. So there's two ways for pregnancy testing. So the first is on the left here. It's called chorionic villus sampling, or CVS. So this would be inserting a catheter to get a very small sample of the placenta. And they can, obviously the placenta comes from the same original genetic material that the embryo does. So testing the tissue of the placenta would give us insight into the genetic makeup of the embryo. This one can be done a little bit earlier, so 10 to 12 weeks. It's going to depend a little bit on the center and the practitioner, but that's usually what that time frame looks like. And this would give us like I said, insight into the status of that embryo. A little bit later is amniocentesis. So this is maybe the more common one that people think about. So this would be inserting a needle using an ultrasound. Both of them use ultrasound into the fluid that's around the baby. And they draw out a little bit of amniotic fluid. And just as we shed skin cells and are consistently doing that, the fetus is doing that as well. So there are skin cells in the amniotic fluid that can be tested to determine which copy of whichever gene in the family is affected that embryo inherited. So it's a genetic test, just like the ones that we do to diagnose people, just very focused on that one variant that we know is in the family, just to get that yes or no answer. So this one, like I said, is done a little bit later. Some of the hesitation that comes along with testing a pregnancy would be that there is a very small risk of miscarriage. It's going to depend on the center. You know, every center has their rates for what they quote as the risk for amnio and CVS in each individual's specific situation. But that would be one of the cons that people consider. Another cons is, you know, if you do this test, what are you going to do with that info? So this isn't something that, you know, we would test a fetus just to know its status. It's not something that's seen as a benefit. So generally this would be a question of, is that, you know, are you choosing to terminate that pregnancy if it comes back positive? So if someone is going to do the amnio and they say, well, I'm not going to change anything no matter what the results are, that would be a question of, well, why are we doing this? You're kind of choosing to know that embryo status. Whereas if it's someone who is, you know, 18, 25, and they're thinking about doing this testing, they have that choice to know their status or not, and you're kind of taking that away from the fetus, right? You know, they won't ever have that choice to say, you know what, I don't want to know my status, because it would have been figured out by doing this testing during the pregnancy. So there's a lot of discussion that goes into doing this kind of testing and thinking about this kind of testing. There's lots of different ethical considerations, religious considerations that people may or may not be okay with this as an option. It's obviously a very emotional process. You know, this can't be done until, you know, 10 to 15, 16, 20 weeks of pregnancy. So that's going to be an emotional process to make that decision. You know, go through all of that, you know, to learn this status and make that decision. Some of the pros would be that there's maybe less of a financial burden with this than some other options, but it's a balance, right? You know, what's right for one person isn't right for another person. So this would be the overview of testing a pregnancy. So the fourth option that I usually talk about with people would be what we call pre-implantation genetic testing. So this has a few different names. It used to be called pre-implantation genetic diagnosis or genetic screening. So it's got a couple different acronyms that you might see depending on what you're reading, but I think the current terminology has kind of moved to this pre-implantation genetic testing. So this is a method of screening embryos for a known genetic condition. This is another one where we do need to know the genetic cause in a family or an individual before we can do this. And we also must perform this in conjunction with IVF. So I'm going to go through the different steps that go into IVF and PGT on the next slide here. So first step would be meeting with a genetic counselor, or, you know, whatever that staff has or whoever that staff has to kind of guide patients through this process. But usually if genetic testing is involved, there's a genetic counselor involved on some level. So talking through the process and, you know, costs and all the things that we'll talk about in a little bit. There's a lot of different testing that goes into it. So blood testing for both partners, semen testing, hormone testing. It's part of the IVF process, but it's also important for PGD because they're, you know, both based on that IVF process. And the testing has to be set up. So what I mean when we say set up is that the blood samples from each parent are taken to the lab, and they basically create a series of probes that kind of light up within the gene and around the gene, because we know our genetic information can kind of swap between the two chromosome copies that we have. So we just want to make sure that the genetic code is clear. We want to know basically the landmarks around the affected parents, you know, a non-working copy of the gene, and the landmarks around their copy of the working gene, because we just want to make sure that we know where that variant is and which copy was inherited by each embryo. So there's a lot of setup with the testing, and it's really necessary because when we do the embryo testing, it's such a limited amount of DNA in such a short period of time. It's really not possible to do that test. We have to have a very specific test set up, ready to go in order to be able to do this. And then once all of that is complete, there is usually some general anesthesia to extract the eggs. So the woman is given medication to make as many eggs as possible, and then those are extracted using an ultrasound probe and a needle to get as many eggs as are mature and can be involved in the IVF process. Then the lab would utilize usually intracytoplasmic sperm injection. So this is a process in which one single sperm is injected into the egg cell, and this is used to reduce contamination. The sperm's whole purpose is to contain genetic information. So if there's extras hanging around, this could definitely affect the PGD testing in a couple of days. We want to make sure that we're only testing the DNA from that embryo and not, sperm that is kind of left over and not actually part of that fertilized embryo process. So some studies have reported an increased risk for sex chromosome abnormalities in children born after ICSI, or this sperm injection process. The risk was reported as about 0.8%, which is increased from the general population risk of 0.2%. It's not clear whether this risk is due to the procedure itself or the population that was studied. A lot of the patients that were studied did have a history of infertility, including male factor infertility. So it's hard to say whether it's coming from the process or from the patient population, but it's definitely something to discuss with the genetic counselor who is kind of leading you through the process. So it's one risk to consider with this process. The embryo is then left alone to grow and divide. And usually there's multiple embryos. So depending on how many eggs were collected, that's the number of embryos that we would hopefully have. So the embryos are watched, evaluated. After a certain number of days, a very small hole is cut into this covering of the embryo, and a few cells are removed with a glass needle. They basically do a very small biopsy on the embryo. So what are the risks of that biopsy? Generally, the biopsy risk is all or nothing. So if there is damage, the embryo stops growing. If it is not damaged, it doesn't become abnormal in any way. The embryo continually has cells that are dying off and being replaced. So the biopsy doesn't, take something away that's going to become a critical structure later. This is the time when there are a lot of cells moving around and growing and changing. So if there are extra embryos, they can be frozen, but this is kind of the testing that's done is on this biopsy for each embryo. So you would get a report that says, these are, embryos 1 through 10, embryos 2, 4, 5 are tested negative and are suitable for transfer. If there are extra embryos, typically places would only transfer 1 or 2 embryos depending on patient's age and preference. If there's extras, they can be frozen. And part of the kind of pre-IVF process would be coming up with a plan for what a patient wants to do with their affected embryos. And that's something that, sometimes there are research programs that are, accepting those kinds of things. There are places that can just keep them frozen. There are people who choose to discard them. There's different options for what to do with any extra embryos. So definitely coming up with that is an important part of the process beforehand. So the chosen number of unaffected embryos are transferred into the uterus with a catheter, and hopefully they will implant and result in a pregnancy. And I will say that most places do still recommend prenatal testing. So they do still recommend looking into an amnio or a CVS. It's not mandatory, and probably not, not a huge percentage of uptake there, just because it takes a lot to go through all of this and achieve that pregnancy. And for some people, the risk of miscarriage that comes along with, the prenatal testing options just isn't worth it for them. So it's just kind of like a double check to say, like, let's make sure that this embryo was indeed unaffected, but in general, the testing is very, very accurate. So lots to talk about with this one, lots of pros, lots of cons. So the pros, this definitely does reduce the risk of disease, right? We're testing the embryos to see which copy of the gene that they inherited and only implanting unaffected embryos by this testing. This is an option as non-disclosure testing. So what that means is that, let's say we have a person who knows they're at 50% risk for an SOD1 variant, and they want to start a family, but they don't want to know their own status. They don't feel like they would be able to handle that. It's not something that they want to hear at this time. Depending on the lab, they are able to do different setups that would allow for embryo screening without telling that person their status. So it's kind of a balancing act, right? So we have, you know, the risk of going through this process when you don't need to. You know, let's say you would have tested negative anyway, so you're going through this process needlessly. You know, they can screen for other things as well, but we're not, you know, actually testing for the variant because you don't have it, versus the psychological distress that someone might feel if they do get their genetic results and they don't want them. So it is an option at some labs, something to talk about if people don't really want to know their own status. It can reduce guilt. You know, it makes people feel that they have done what they can. You know, if people are wanting to do something to reduce that risk of passing it on. There isn't an increased risk of birth defects. This is something to discuss with the center and the people doing that, just to get their numbers and their insight on this, but it is not, you know, something that is considered an increased risk. On the con side, it is a numbers game. You know, we do start out with, you know, the number of follicles that a person has, and then the number of eggs that those end up producing, how many of those eggs mature, how many fertilize normally, how many are still developing after the biopsy, and then how many are normal after the genetic testing. So you want to start off with, you know, the most follicles and eggs as possible, and that is a stressful process. It is considered experimental. I will say most genetic counseling is considered genetic testing is considered experimental too, so it can affect whether or not it's going to be covered by insurance. So that's something to look into ahead of time to know if there's any exclusions or, you know, fertility kind of things that need to be looked into before an insurance company will cover this. It's emotional. It's a really long process. It's a lot of hard things to go through. It's big decisions to make. It's and all the while you're having, you know, for the female at least, hormones that are introduced into your system that can make that even more emotional. Other people have issues with the ethical considerations that go along with this process, and that's something to factor into your decision if you're okay with this or not, and what that would mean to you. The take-home baby rate is also going to be clinic dependent. So this is going to be, you know, what is their rate for individuals for, you know, who come in with fertility reasons or without fertility reasons, just for PGT. That's something to consider, is that, you know, it doesn't, you know, just because someone goes through a cycle, it doesn't necessarily mean that will result in a pregnancy. And that's kind of part of the emotional process. You know, it's hard to go through all of this and then not have a positive pregnancy test. And they recommend prenatal testing anyway, which some people would see as a con. You know, they definitely don't or may not want to go ahead with that and do that testing. So that can be a hard thing to hear when you're setting up this whole process. And another con that some people say is, you know, we can't predict the future. We don't know what treatments or drugs will be available moving forward by the time a pregnancy that's being conceived now would be at risk for these kinds of symptoms. And there's also the risk of multiple births. I think we all heard the story of Octomom years and years ago. I think things have changed that, you know, they are very careful about the number of embryos that are are transferred, but there is an increased risk for twins and triplets, and that can be hard as well. And it's expensive. So that's probably the biggest con with pre-implantation genetic testing, is the cost. So financial overview, you know, IVF cycles, and this is going to vary depending on where in the country you are and what your center has, but, you know, $10,000 to $12,000 per cycle. Depending on the PGD testing that you're adding, that could be an additional $2,500, $6,000, depending on, you know, how much testing is done. Usually more than one cycle is necessary, so this can really be an economic barrier for people. There are laws requiring coverage of IVF in these different processes, so that's something to look into depending on where you are and also what your insurance mandates, you know, what they will cover and I will say that the genetic counselors who do this are really great at writing letters of medical necessity to explain why this is necessary and what the benefit will be, and kind of put it in terms that the insurance company can understand and approve. So there is a committee opinion from the American Society of Reproductive Medicine that basically says that PGD, this is back when it was called PGD, for adult onset conditions is ethically justified when the condition is serious and no safe, effective interventions are available. It is ethically allowed for conditions of lesser severity or penetrance. The committee strongly recommends that an experienced genetic counselor play a major role in counseling patients during considering such procedures. So kind of reiterating what I've gone over with you guys, but in general, this is something that exists, and a lot of people do take advantage of it. So overall, all of these methods that I've talked about have pros, they all have cons. No option is going to be perfect for every single person. It's really going to depend on, everyone's individual finances, their different biological considerations, relationships with the child, their own biology, ethical considerations. So I think it's, a lot of reproductive things are kind of taboo and not as talked about as much in families. So this is one where we try to be really encouraging, definitely talking to, your partner, genetic counselor, therapist, religious leaders. There's lots of perspectives out there, and depending on how you make decisions in the past and what information is helpful for you, maybe getting some additional people to talk to or input could be helpful. No, it's not true for everyone, but it's things to think about that could be helpful when someone's trying to make a decision like this. So some things to consider, and I've gone over a few of these. You must have a confirmed familial mutation or variant. So we have to know what's causing the disease in the family for some of these. Others, we don't necessarily need that, but if we want to do any of the ones that involve testing, that's something we would need. PGD can have implications for family members' risks, right? So let's say we have the grandfather of these prospective children who doesn't want to be tested, but his daughter, who would be the mother, wants to have PGD for her offspring. If she gets tested or undergoes PGD and realizes that she is, she carries that genetic variant, that would reveal the grandfather's status, right? If he doesn't want to get tested, but we know that the daughter has inherited it, it clues us in that is something that he has as well. So that could be a tricky thing to navigate, and we, would prefer not to have people knowing someone else's genetic status. That's a pretty big secret to keep and have. Also important to consider, people can undergo IVF with PGD without learning your status. You don't have to be tested to go through that process. None of these are risk-free, but there are definitely reproductive options out there for FALS family members. So just want a little plug for some reproductive research. I had a former student who did a study entitled Decision Making About Reproductive Choices Among Individuals at Risk for Familial ALS in Families with a Known Genetic Variant. So this was a study that she did as her thesis, and she utilized patients who had enrolled in one of the Northwestern Research Laboratories registries. So she basically talked to people who were in that position and asked, if they did have children, why did they choose to have children? If they didn't have children, why did they choose not to have children? And kind of talked about some of the reproductive options. Most of the people that she talked to had already made their family planning decision, so some of it was kind of speculative, but in general, for the people that chose to have children, one of the things that they cited was that regardless of the disease onset, people can still have a productive life. They could still have a life that they can accomplish things and change things and be a full, complete person. People who chose to have children also cited that they compared ALS relatively favorably to other diseases, that they had always planned on having children, and that they hoped that a cure would be found in the near future. So a lot of this is dependent on their outlook, right? It sounds like these people have a specific experience with the disease. For people who chose not to have children, in general, they tended to have a little bit more extensive experience with ALS caretaking, so maybe a different perspective on the disease and the types of symptoms that it can cause, and tended to see ALS as a little bit more tragic, and as a part of that, avoided serious relationships. So these tended to be people who maybe were a little bit more strongly affected by knowing that ALS was in their family and seeing their own risk there. So all of the individuals did consider other reproductive options. PGD was not available for most of them, but they were definitely intrigued by it and said that they would have looked into it if that had been an option when they were choosing to start their families. So in conclusion, genetic counseling can definitely extend beyond the testing process. I am available, and most of my colleagues are available elsewhere for family meetings, follow-up visits, email questions, calls, all kinds of things. And we can also recommend specialists or centers that are familiar with these issues. So if someone's looking for an IVF center or PGT, we have recommendations for that. Or people can find a genetic counselor using the Find a Genetic Counselor tool at this website. And I'm more than happy to answer questions that people have now or after the talk. So I would love to hear any questions that you guys have about anything that I've gone over or things that I didn't go over.
Lisa, you can come up and join me while we do Q&A.
Sure.
Great. That was so great. And I know obviously it's such an individual decision, and I really think you laid out beautifully so much to consider and think about, but I think you did a really great job of letting people know the pros and cons and all the implications involved. So thank you so much. Let's see, I just asked people to type in the chat box if they have questions. They can type their questions here in the chat box to the right. It's on the dashboard.
I'm trying to load my webcam. It's not cooperating. One second.
I see you.
You do? Oh, okay. Maybe I just can't see myself.
So while we're waiting, Lisa, let me ask you, what are some common questions that you receive, and any additional information or insight you can offer to the audience today?
I mean, I think I've included a lot. I mean, a lot of the common questions would be on the financial side, right? Because there are a lot of, variability in how much these things cost and what people's resources are, whether or not insurance is going to cover it. I think that would probably be the biggest thing. But a lot of the people that talk to me come in because they want to be tested because this is their goal, right? They need to know their status because they want to know if they want to utilize any of these things. So really depends on how decided they are and what their initial indication is. So, if they're coming in for pre-symptomatic testing because they want to decide on this, then it's a little bit more straightforward, but definitely always finances. And, I really encourage people to kind of talk to practitioners that are available. It's like I said, a lot of these are emotional things to go through. So having, someone that you're comfortable with, a center that you're comfortable with, people that you feel are good at communicating with you about what's going on, that's hugely important. So that would be a big recommendation that I would have for people who are kind of looking at this process.
Yeah, no, that's helpful. That's absolutely helpful. While I'm not seeing any additional questions in the chat box, can people email me, Lisa, if they have additional questions after the webinar, and I'll forward those to you?
Yeah, definitely. Feel free
Okay.
to send an email, and I can always answer things that way.
Fantastic. Well, this was fantastic. We thank you so much for sharing your knowledge, your expertise, just such important information, Lisa. And we're always happy to have you work alongside of us for the families and individuals we serve. So thank you so much, and have a great rest of your week.
Thank you.
I'll close out the webinar here for everyone else. Okay. We're just waiting on the slides to advance.
On mine? Okay.
No, you're good, Lisa.
Oh, okay.
Yeah. You can take yours down, Lisa.
I
You're still on camera, but you know what? I'll move forward while you're on camera. You're welcome to join us, Lisa.
Oh,
Um,
okay.
yeah, absolutely. So again, I want everyone to join us next month. We will be having a webinar with Martha Twaddle, who is a doctor at Northwestern Medicine. She'll be talking about hospice and palliative care for people with ALS. That will be happening on Thursday, November 11th at noon. And then also do not forget to join us for our annual symposium, which will be happening on November 1st. Dr. Brown from the University of Massachusetts Medical School will be giving the keynote address on new direction in ALS therapies. Dr. Brown has a longstanding research interest in identifying gene defects that underlie ALS and related neuromuscular disorders. His laboratory team has used insights from these investigations in genetics to generate cell and animal models of each of these disorders. Most recently, he has initiated trials of gene suppression therapy, SOD1, and C9orf72. The symposium will discuss the latest advances in ALS research and clinical studies, as well as provide those living with ALS and their families beneficial and important information related to their care. So I want to thank all of you, especially to Lisa for sharing her knowledge and expertise today, and for those of you who have been so patient in dealing with our little technical issues here today. So thank you for spending time with us. We look forward to seeing you next month, and you will receive a survey immediately after this webinar. So please take a moment and fill that out. We appreciate your feedback. Thank you so much. Bye-bye.